Good day and welcome to the 2020 National Ryan White Conference on HIV Care and Treatment Virtual Edition. I'm Laura Cheever, the Associate Administrator of the HIV/AIDS Bureau at the Health Resources and Services Administration, coming to you live from Rockville, Maryland. It's my pleasure to be with you today, albeit virtually. We have over 6,000 people registered to attend, and apparently 8,000 people currently listening, so figure that out, from all over the U.S., Puerto Rico, the Virgin Islands, Pacific jurisdictions, and even some of our esteemed global colleagues. You represent Ryan White HIV/AIDS program grant recipients, people with HIV, health service providers, national stakeholder partners, and federal agencies. We're also pleased to welcome Mrs. Jeannie Ginder White, Ryan White's mother, who will be joining us for the closing plenary on Friday, so don't miss that. Once again, thank you for joining today. The theme of this year's conference is 30 years of innovating care, optimizing public health, ending the HIV epidemic. This Monday marks the 30th anniversary of the Ryan White Care Act. First enacted August 18, 1990, the legislation created a federal program focused specifically on providing HIV care and treatment services for low-income people with HIV who are uninsured and underinsured. It was created in part because of the overwhelming stigma that people with HIV faced in the medical system and greater society. We have learned much about HIV and had phenomenal improvements in treatment over the past 30 years. The theme recognizes the Ryan White program's contribution to the advancement of HIV care, treatment, and public health over these past 30 years, and highlights the program's commitment to leveraging powerful tools to end the HIV epidemic in America. Across the program today, you do tremendous work to bring outstanding care and support services to the most vulnerable people, despite the HIV stigma, homophobia, and racism that persists today. We need to address these persistent challenges if we are going to end the HIV epidemic in the next 10 years. Over the past year, as part of the Ending the HIV Epidemic initiative and prior to the COVID-19 pandemic, I was honored to travel the country and meet with Ryan White recipients and stakeholders. Through these sessions, focused on the gap between where we are now and where we want to be, I gained new insights into your challenges and the innovative approaches you're taking to overcome these barriers. I hope we have an opportunity to continue these in-person engagements with you, our dedicated Ryan White recipients and stakeholders, but in the meantime, we're committed to finding effective ways to engage virtually. I know that the conference looked a little different this year due to the COVID-19 pandemic. However, we have worked hard to provide a format and platform that allow you to experience much of what you do when we're in person, and that this time will offer you a time for reflection and celebration, as well as productive exchange of valuable knowledge, information, and best practices. Let me take a few minutes to talk about some of these features that we've built into the conference platform. First, networking has always been a key feature of this conference. Go back one. Oh, sorry. Please be sure to create your profile and e-business card under the My Network section of the platform. You can also view the conference attendee list and make connections with your colleagues. Second, at the last conference, I, who am a complete media troglodyte, took great delight in our in-app social media feed. It's actually the first time I've done social media. During this conference, please post about the conference on social media. When you use the hashtag RyanWhite2020, your post will show up on the platform's social feed. You also have the option of directly posting to the platform social feed. Please take a few minutes to post your impressions and insights throughout the conference. Finally, to celebrate the 30th anniversary of the Ryan White Care Act, we're asking participants to download the I Care Because flyer from the resource section of the platform, fill it in, and post a picture of yourself with the flyer to our photo gallery. We'll use images throughout the remainder of the year to highlight how the Ryan White HIV/AIDS program has affected the lives of our stakeholders. Please participate, and you can go over there now and see what I said. We have an ambitious and exciting agenda for this week. Please join me in thanking the Ryan White Conference Planning Committee, especially the conference executive co-chairs, Melinda Tinsley, Commander Kathleen Davies, and Tamika Martin, for their hard work and commitment in providing with a successful conference. When they agreed to co-chair this meeting once again this year, in addition to all of their regular duties, they were thinking, how hard could it be, given their experience? Well, COVID certainly upended their plans and our usual plans here in HRSA, and I know it did as well as in your programs. We're going to kick off the conference with a timely video showcasing the work that our recipients, subrecipients, and stakeholders are doing to address the COVID-19 public health emergency.
My name is Noel Tolbach. I serve as the Chief Executive Officer for Crescent Care in New Orleans, Louisiana. The Ryan White CARES Act funding has enabled us to continue to provide services for people living with HIV, but also making sure that we are able to deliver services in maybe a not so traditional fashion. But this pandemic is causing us to rethink that maybe there's a better way to do it where we can get those same results of culturally humble and high quality care, but that might be a little bit more convenient for our constituents. Some of the lessons that at least I've learned has been to really turn to our frontline staff, the people that are working directly with the individuals that we are serving, and rely on their ingenuity and creativity and the incredible imagination that people have been able to utilize in figuring out how can we do these systems better and how can we make services more available to people that we're working with.
My name is Mark Baker. I am the Chief Operations Officer for Lifelong AIDS Alliance. The additional CARES Act funding has helped us tremendously in being able to continue providing services to our clients across all of our programs. We were able to deploy all of our staff to work from home and immediately begin providing telehealth services. And in a number of cases, we're getting reports from our team that they are engaging with clients at a much more frequent level, and some of them much more intensely. Additionally, we've been able to use the CARES Act fund to send personal protective equipment that includes face masks, gloves, hand sanitizer, thermometers so they can monitor their temperature to help our clients protect themselves from the spread of the disease. We've also been able to launch a client financial assistance program through those funds. We're changing our medical transportation and focusing more on taxi vouchers to avoid public transportation. So we're really trying to leverage our funds that we have in every possible way to help clients stay home and stay safe. So the lessons learned for us have been, we can do this, we just need to be flexible, and we need to be mindful of the trauma that our community is experiencing.
I am Jeffrey Morris, and I work with the Illinois Department of Public Health. I am the administrator of the Ryan White Part B program. CARES Act money allowed us to assist security and safety around housing, transportation to medical facilities. For some of our clients that were tested positive for COVID and then were quarantined at home, we used that funding to help network food delivery. HRSA was wonderful in opening up that avenue to many of the Part Bs and actually statewide in the other parts. I have to say I was very proud of our HRSA national partner that helped us at the state level navigate what could have been a challenging process that we didn't have initially planned out in the early stages of the pandemic.
My name is Dr. David Rosenthal. I'm the medical director for the Center for Young Adult, Adolescent, and Pediatric HIV at Northwell Health in New Hyde Park, New York, and I'm a recipient of Ryan White Part D funding. So the Ryan White HIV CARES Act program has really provided outstanding resources for our program. During the COVID-19 pandemic, we were able to create regular conference calls and regular Zoom meetings where we're able to interact with our team members, where we get together more frequently than we would in person as an entire staff to talk about the needs of our patients, to talk about what worked, to talk about what new ways we're able to use to engage patients and have patients receive the kinds of care that they needed to receive. So COVID-19 taught us many, many lessons. I think the most important lesson is to be flexible and to make sure that we can always look forward. What worked yesterday will not necessarily work tomorrow. And so what we need to do is we need to innovate at every single opportunity. We need to be able to be creative and be able to come up with new ways to reach our patients and to be able to communicate with our staff and team members.
I want to reiterate my thanks for your tremendous efforts in continuing the important work of the Ryan White HIV/AIDS program while responding to the exigencies of the COVID-19 pandemic. Really, we didn't drop a stitch in terms of getting medications to patients and the essential care they needed. I'd now like to take a few minutes to reflect on the progress we together continue to make in the program. Thank you for your continued efforts in providing client-level data to us. This data allows us to clearly demonstrate who you serve and give insights into the impact of the program. As this infographic shows, over 500,000 individuals in 2018 received Ryan White services, representing half of all those diagnosed with HIV in the United States. It has a tremendous impact across the nation. Of these clients, close to 3/4 were from racial and ethnic minority populations, 60% lived at or below 100% of the federal poverty level, and almost half of our clients were 50 years or older, something to celebrate as care and treatment improved longevity. Also, a new challenge for us is as these people that are aging with HIV are the first generation to do so, and we have much to learn from them and much to give them. Turning now to the impact of the program, in 2018, 87.1% of Ryan White program clients who came into care at least once were virally suppressed, exceeding the national average of 65%. That's up from 69.5% of clients who were virally suppressed in 2010. And it's really a testament to the remarkable work that you do every day to reach people with HIV in your communities and to offer effective patient-centered care. Breaking down the national data by state, where lighter colors signify higher viral suppression rates, you can see every state has made progress since 2010. However, disparities among states persist in 2018, particularly in the Southeast, which needs to be an area of continued focus. Because of the work that you've done in so many different ways, we've been able to significantly reduce racial, ethnic, gender, and age-related disparities. As you can see on this slide, where the darker column is the viral suppression by key population in 2010, and the lighter green is viral suppression in 2018, viral suppression has improved for every population. Importantly, the disparity gaps have been reduced for all populations except the unstably housed. If we are going to further reduce and eventually eliminate these disparities, we must address the social determinants of health and the racism that undergirds them. This is the work that we have for us in the coming years. Over the next few days, we'll talk about those challenges and the innovative and collaborative work we are all doing to end the HIV epidemic. Today, we have a panel of speakers who are national leaders in the federal effort to end the HIV epidemic, as well as the COVID-19 pandemic. They'll highlight the critical role of the Ryan White HIV/AIDS program's public health response to HIV, policy, and scientific advances over the past few years that are helping move us forward towards ending the HIV epidemic. We're honored to have HRSA Administrator Tom Engels, HHS Secretary Alex Azar, and NIAID Director Dr. Anthony Fauci here today. Tom Engels joined HRSA as the agency's administrator in August of 2019. He also currently serves on the White House COVID Task Force. Before coming to HRSA, Mr. Engels was the Deputy Secretary of the Wisconsin Department of Health from 2015 to 2019. In that role, he championed and oversaw the expansion of the state's capacity to provide mental health services, the implementation of a statewide electronic health record system, and a reduction in staff shortages in long-term care facilities. He was also an active member of the governor's task force for opioid abuse and chaired the governor's Human Resources Shared Services Executive Committee. Please welcome HRSA Administrator Tom Engels. Tom?
I'm sorry. Well, thank you. My internet keeps freezing up here. Thank you, Dr. Cheever, for that warm introduction and for your leadership here at HRSA and in the HIV/AIDS program, and for all the leadership you've shown across the country. I am pleased to have the opportunity to speak with you this afternoon on behalf of HRSA. I would like to thank you for joining us for what is sure to be an exceptional conference, even given these unique circumstances. The mission of HRSA is to improve health outcomes and eliminate health disparities through access to quality services, a skilled workforce, and innovative programs. And it's events like this that remind us that HRSA is not alone in our mission. All of you and many of you across the country and across the federal government, our partners and stakeholders across the country and around the world, are also working to improve the health of our communities. HRSA supports more than 90 programs that provide health care to people who are geographically isolated, economically, or medically challenged. Every year, HRSA programs serve tens of millions of people, including people with HIV, AIDS, pregnant women, mothers and their families, and those otherwise unable to access quality health care. HRSA has 4 strategic goals, each which aligns with the work of the Ryan White HIV/AIDS program. They improve access to quality health services, foster a healthcare workforce able to address current and emergent needs, achieve health equity and enhance population health, optimize HRSA operations, and strengthen program management. Adhering to these strategic and operational goals enhances our support for the great programs that all of you, our partners, are implementing on the ground. Together, our work translates into meaningful change in the lives of populations we serve. This year has brought many challenges, and your dedication to meeting those challenges is inspiring. As the novel coronavirus, or COVID-19, has affected our lives, communities, friends, and loved ones, HRSA has maintained our commitment to our existing portfolio while stepping up to play a critical role in the response to the pandemic. HRSA has been and remains today one of our leader among federal agencies combating this new threat to our nation. We fully recognize the extraordinary impact of this public health crisis has had on our grantees and organizations that are important partners of HRSA's. To that end, HRSA has responded quickly and with great purpose. We've swiftly mobilized significant COVID-19 related efforts to directly support the American people. In April, HHS charged HRSA with managing the distribution of the $175 billion appropriation by Congress, known as the Provider Relief Fund. These federal dollars will bring relief to hospitals and other healthcare providers on the front lines of the coronavirus response by providing payments to reimburse healthcare expenses or lost revenue due to COVID-19 impacts. As part of the Provider Relief Fund, along with the additional $2 billion of emergency COVID-19 funding, HRSA manages the COVID-19 claims reimbursement to healthcare providers and facilities for testing and treatment of the uninsured. This allows healthcare providers who have conducted COVID-19 testing or provided treatment for uninsured individuals with a COVID-19 diagnosis since February 4th, 2020, to submit claims for reimbursement. This program ensures that the uninsured individuals are tested and receive treatment for COVID-19 and are not billed for these services. There is a lot more about this information about this program on the HRSA website. Since March, through our own HRSA programs, such as the health centers and the Ryan White HIV/AIDS program, we have awarded more than $2.5 billion to combat the coronavirus. These awards are broadly strengthening access to telehealth, expanding COVID-19 testing in rural and tribal communities, and building healthcare centers' capacity to diagnose and treat the disease. These emergency funds have been instrumental in sustaining services provided through the Ryan White HIV/AIDS program. At this time, more than ever, we understand the critical role that we and partners like you play in improving the health of people with HIV. I invite you to get the latest information about HRSA's role in the fight against COVID-19 at www.hrsa.gov/coronavirus. Last year, the administration announced the ending of the HIV epidemic, A Plan for America, a 10-year initiative to reduce new HIV infections to fewer than 3,000 cases by the year 2030. The initiative is focusing efforts on 48 counties, Washington, D.C., San Juan, Puerto Rico, where more than 50% of the HIV diagnosis occurred in 2016 and 17, as well as an additional 7 states with substantial number of HIV diagnosis in rural areas. For 3 decades, HRSA's Ryan White HIV/AIDS program has played a critical role in the United States' response to ending the HIV epidemic. Through HRSA's Ryan White HIV/AIDS program and the HRSA-funded Health Center program, the agency is playing a leading role in helping to diagnose, treat, prevent, and respond to the HIV epidemic in the United States. In May 2019, Gilead Sciences Incorporated agreed to donate pre-exposure prophylaxis, known as PrEP, for up to 200,000 individuals each year for 11 years. This donation is central to the department's Ready, Set, PrEP, a nationwide program led by the HHS that provides PrEP medications at no cost to thousands of individuals who qualify. HRSA Health Center program plays a major role in this initiative, helping to expand access to PrEP, reduce new HIV infections, and bring us one step closer to ending the HIV epidemic in the United States. I know you will be hearing a great deal about the HRSA's role in the initiative throughout the conference. I had the pleasure of taking part in a number of the HIV/AIDS Bureau's Ending the HIV Epidemic Initiative websites in a recent Have You Heard webinars. At the same time, I was pleased to learn about some of the early promising practices among the Ending the HIV Epidemic Initiative focused jurisdictions like Kentucky Income Reinvestment Program, Boston's Healthcare for the Homeless model, and the Phoenix Rapid Start Program. These emerging initiatives models of care truly demonstrate what is at heart of this initiative, thinking differently about how to reach the vulnerable and bring them care as they deal with HIV. Our agency works with everyone here in the audience. You, local, state, national leaders on the front lines translating the latest science into practice, are pursuing effective and evidence-based strategies, providing direct patient services, and using data and innovation to improve the lives of people with HIV. HRSA is committed to increasing access to HIV prevention, care, and treatment services, and collaborating with you and our many partners to help end the HIV epidemic. I thank you and appreciate all you are doing to provide services critical to improving the lives of people with HIV. Now it's my honor to introduce Secretary Azar. Alex Azar was sworn in as President Trump's Secretary of Health and Human Services in January of 2018. His current tenure as HHS is his second tour of duty at the department after serving as General Counsel and then Deputy Secretary in the 2000s. He has spent his career working in senior healthcare leadership roles in both public and private sector. It is a pleasure to introduce you to the 24th Secretary of the U.S. Secretary of Health and Human Services, Alex Azar. Mr. Secretary.
Hello, everyone, and thank you for inviting me to address all of you today. It's unfortunate that we couldn't gather in person this year, but I'm glad so many key stakeholders in our country's fight against HIV/AIDS are still gathering virtually for this important event. This year, we mark the 30th anniversary of the legislation that created the Ryan White HIV/AIDS program, and I want to congratulate all of you on the incredible progress we've seen since then. As all of you know, in 2018, the share of your clients who were virally suppressed rose again to 87.1%, far above the national average. This is a remarkable accomplishment, and I want to congratulate all of you on the work that made it possible. Given this anniversary, it is fitting that we're now launching the next major chapter in our country's work to defeat HIV/AIDS, the President's initiative to end the HIV epidemic in America within 10 years. Since the initiative's announcement last year, we've been securing funding, consulting with communities, and helping jurisdictions lay out the plans necessary to cut HIV transmissions by 90% over the next decade. This year, we faced a monumental new challenge, the COVID-19 pandemic. Today, I want to emphasize that we have not let up in our work on vital public health priorities because of the pandemic response. COVID-19 requires a great deal of focus, but America's other pressing public health challenges have not grown any less important. In fact, our public health response to COVID-19 cannot be separated from our work to combat health disparities and promote health on other fronts. We've recognized that through the support we've sent to Ryan White HIV/AIDS program recipients earlier this year under the CARES Act, and we've continued charging ahead with the Ending the HIV Epidemic initiative. In March, HRSA awarded approximately $117 million to the Ryan White HIV/AIDS program and HRSA-funded health centers to expand access to HIV care, treatment, medication, and prevention services. This investment is critical to the work many of you are doing as part of the EHE initiative. In addition, at the end of July, CDC released $109 million to public health authorities in the 57 state and local jurisdictions we've prioritized under the initiative, which together account for more than half of the new HIV infections in America. These jurisdictions are developing plans to meet the needs of the communities they serve, and these plans universally involve a critical role for the Ryan White HIV/AIDS program. You bring not only crucial expertise in delivering public health and medical services, but also deep experience connecting with communities and combating the stigma that makes it harder to reach those who need services the most. Much of this stigma comes from outdated, inaccurate ideas about HIV/AIDS, dating back to its early days. Stigma can be a debilitating barrier, preventing people with HIV or at risk for HIV from receiving the care, services, and respect they need and deserve. We know stigma can be an even greater challenge when it intersects with populations that have been historically marginalized, such as Black Americans and gay men. To help marginalized populations fighting this disease, we know we need to listen to them, to engage with them even more deeply, and learn from their experiences. Each of you will continue to play a key role in that effort. Your dedicated work throughout the COVID-19 pandemic has been appreciated from the very top of HHS. We recognize how difficult this work has been, and we're deeply grateful for your efforts. These efforts make me all the more confident that together we can achieve the goals we've set out, not just making HIV another manageable chronic condition, but ending the HIV epidemic in America by 2030. Thank you for the work you've done already toward that goal. Thank you for the work you're doing during these challenging times, and thank you for the honor of addressing you today.
Thank you so much, Mr. Secretary. Our next speaker really needs no introduction. For many years, Dr. Fauci has led the National Institutes of Health Institute of Allergy and Infectious Diseases. He's championed many of the efforts in the global fight for ending the HIV epidemic and a national leader in many important public health efforts, including currently our response to coronavirus. Dr. Fauci?
Greetings. My name is Tony Fauci, Director of the National Institute of Allergy and Infectious Diseases, and I'm very pleased to be here with you virtually to present at the 2020 National Ryan White Conference on HIV care and treatment. As you can see from this title slide, I'll be talking to you today about ending the HIV epidemic and the research and implementation progress that we have made towards that goal. Some of you may remember in March of 2019, my colleagues and I wrote an editorial in JAMA called Ending the HIV Epidemic, a Plan for the United States. Now, before I get into the nuts and bolts of that and how we have done over the last year, just to remind individuals, as shown on this slide, of the burden of infection, disease, and death in the United States, the important number being that there are 38,000 people who are newly diagnosed with HIV in 2018. And that's the thing that we need to do if we really want to end the epidemic, is to be able to use the tools that you'll see that we have to get that number dramatically down. But in order to do that, I would like to just take a little bit of time to tell you why we think today we can and will be able to do that, because we have a solid scientific basis for this plan. Namely, we have the tools. So what are we talking about? You know, last year when I made one of the original presentations, I spoke about the toolkits for both treatment and prevention, which are shown on this slide. I need not go over every single one of these, but it's very clear that we have combination treatments that can transform the lives of HIV-infected individuals, and also combinations of prevention, which have now been proven, if implemented, actually work. And this is even in the absence of a vaccine, which I will get to shortly. Now, there have been some game-changing concepts in addressing HIV that have really founded on the concept of treatment does equal prevention in two ways, both as treatment as prevention, which means that, in fact, if you bring the viral load, as we all know now, if you bring it to below detectable level, you do not transmit to an uninfected partner, therefore allowing us to say, with a true scientific basis, that undetectable does indeed equal untransmittable. But there's another part of the treatment equals prevention, and that is in pre-exposure prophylaxis, or PrEP. And again, with good scientific data, we know when there's optimal, consistent use of Truvada, there's about a 99% effectiveness in preventing the sexual HIV acquisition of an uninfected individual. So you put these two things together, and they really are game-changing concepts. What is the issue and what is the problem? The issue and the problem is that the treatment and prevention implementation gaps exist in addressing the HIV prevention. And these are some of the gaps that we see, both in testing and treatment, retention and care, suppression of virus, harm and reduction services, food and housing insecurity, human rights, the stigma that still remains with us. So when we put the plan together to end the HIV epidemic in the United States, as I'll mention in a moment, the goal of decreasing by 75% new infections in 5 years and 90% reduction in 10 for 4 major ways of achieving it: diagnosing, treating, preventing, and responding to outbreaks. How are we going to do this? Well, this is the way it looks hypothetically on the scale of years, that we want to be at 75% reduction by 2025 and 90% reduction by 2030. This is a multi-agency HHS role in the plan. I'm not going to go through each and every one of these right now, but I'm going to get back to one or more of these shortly. The point that I want to make with this slide is that we have the CDC, HRSA, the Indian Health Service, SAMHSA, NIH, all pulling together to be able to get this plan implemented in a way that will be the success that we hope it will be. Now, why do we think now that maybe we didn't have this opportunity some time ago? Well, it became aware that we actually can focus our efforts. And you focus on what I call the HIV Vulnerability Profile, both demographically and geographically. From a demographic standpoint, it's very clear, numbers you all know so well. 13% of the US population is African American. 43% of all new HIV diagnoses are among African Americans. 60% are men who have sex with men, and 75% are under the age of 35. In addition, there's geographic vulnerability. If you look at the relative percentage of new diagnoses in the United States by geographic area, the southern part of the country accounts for more than 50% of these. And in fact, if you look at the map of the United States with the 3,141 counties or county equivalents, those little boxes on the side, that more than 50% of the infections, of the new diagnoses, are in these counties, in addition to the District of Columbia and San Juan. And the study and the states that are in the lighter blue color, not the dark blue, are those southern states that have a disproportionate infection among the rural individuals, namely not those living in the big cities of these southern states. And so how do we implement? We wrote a paper a little bit ago on the role of implementation science, in which you link fundamental discovery science and innovation science in ending the epidemic at the community level. And that gets to one of the many important components of this plan that I'll focus on, is the implementation science that is going to be done by the NIH, in which we will collect and disseminate data on the effectiveness of approaches, and therefore we can inform the work of the other agencies in what they need to do. This will be done by a number of components, but particularly the Centers for AIDS Research and the AIDS Research Center sites. They are distributed throughout the country, and you can see geographically, although some areas do not have that overlap, there's a good deal of overlap between our Centers for AIDS Research and our AIDS Research Centers. And they will be the main groups that will be implementing this type of science. So for those of you not familiar, the Centers for AIDS Research provide administrative and shared research support by synergistically enhancing and coordinating high-quality HIV/AIDS research. They stimulate scientific collaboration. They support basic translational as well as implementation and health policy research, and they support research on HIV prevention and treatment. I'm going to go through several of these quickly, both to give you an idea of where they are and what they do and how they can interact with the Ryan White program. We have a CFAR at the University of Alabama at Birmingham. We have one at Emory University, and we have them throughout the country, as I showed you on the previous map. I use those two because they're going to be sort of prototypes of things that we can do, but I'm going to show you others in other parts of the country. Now, what we're going to talk about in the next couple of minutes are the selected collaborations between the CFARs and the ARC projects and Ryan White funded programs. I'll go very quickly because I just want to give you these. Remember, these are selected collaborations. There are many more than what I'm going to show you. First, for some of you in the audience, which I'm sure many are familiar with this or not, are the broad geographic distribution of the HRSA community health centers that serve more than 28 million patients. Now, if you look at the University of Alabama CFAR and the Ryan White clinics, the Protect All, which is a PrEP optimization through the enhanced capture of treatment, it's a major collaboration and provides care to around 80% of all patients with HIV in Alabama. Then there's the Emory CFAR with the Ryan White clinics exploring the integration of HIV and mental health care for young Black gay men. And you can see on the left-hand part of the slide at Grady, around 6,000 patients, freestanding clinic, mental health, and at Emory also 2,000 patients. In Tennessee, we have a program the Tennessee Center for AIDS Research a step towards ending the HIV epidemic in the Memphis, Shelby County, Tennessee, by improving linkage to care with a test and treat program. And then there's the Hopkins at Baltimore, Maryland, with the link to the Ryan White Clinic, the Baltimore Rapid Start Coalition. In San Francisco, the UCSF CFAR works with the Ryan White Access Program for HIV care in the San Francisco Bay Area. In New York City, the AIDS Research Center, ending the epidemic for young adults living with HIV that leverages the Ryan White Part A services to improve health outcomes. Now, again, that's just a really, I would say, relatively brief selection of the extraordinary interactions that we have and why we think HRSA is such an important part, a critical part in how we're going to be able to end the epidemic here in the United States and perhaps even serve as a model for the rest of the world. But what are the key challenges for the HIV research community, as well as the community of implementers? And that is to optimize these HIV treatment and prevention toolkits. So let's get back to the toolkits we're talking about. Maximally implementing the current HIV tools that we have. In other words, before we even get to the development of new and improved tools, how do we take those extraordinary boxes and toolkits of both treatment and prevention and maximally implement them? Well, that's where the Ryan White HIV/AIDS program comes in, because more than 50% of people with diagnosed HIV in the United States receive services. The extraordinary accomplishment of 87+% of clients that are virally suppressed, exceeding the national average of almost 63%. And the funding for this, as you see, is considerable at $2.4 billion. If you look over a period of time of the program and how it has gone up from around 70% in 2010 to 87.1% right now, again, a very important and impressive example of what can be done. Now, what we're now seeing in different parts of the country is the decreased time from the diagnosis to care to the initiation and to virological suppression that has been accomplished in places like San Francisco with their very now model rapid program. And if you look at the gaps by evaluating them and improving the immediate linkage and on initiation, this is what you see in the city of San Francisco. The same in Baltimore when you look at the new HIV diagnoses over a period of time. Now, again, just a couple of examples of what intensive implementation can do within the context of what's available from a medical center standpoint, the research standpoint, and above all, and importantly, what you all do with HRSA. But let me just spend a little bit of time talking about the development of new and improved tools. So again, the two major components, treatment and prevention. What about new and improved tools in treatment? I don't want to go through all of the tools that have been developed over the past few years, but there are things that we are now paying attention to, such as newer anti-HIV drugs that are effective during pregnancy. The antiviral drug dolutegravir and emtricitabine tenofovir alafenamide is comprised probably the safest and most effective HIV treatment regimen that's currently available during pregnancy. And this was an announcement that was made just a few months ago, as it were, in March of 2020. And then a couple of months later, the FDA approved drugs to treat infants and children with HIV, namely the dolutegravir tablets and dolutegravir tablets for suspension to treat HIV infection in pediatric patients, something that has always been an issue of making sure we get the best of available treatment, such as these drugs, in a formulation that are applicable to children. Now, there's another aspect of this, and that is how can we durably control HIV infection in the absence of daily antiretroviral therapy? which for many becomes a difficult thing to do for an extended period of time. The durable control of virus without the need for daily ART has three components. The first is eradication, and I don't have the time to go into that with you now because I want to focus on two others: long-acting antiretroviral therapy. Now, again, just a couple of months ago, published in the New England Journal of Medicine, was the demonstration that once monthly injectable anti-HIV treatment in the form of cabotegravir and rilpivirine over oral induction for HIV infection is that participants in the both trials preferred monthly injections over daily oral therapy. What about broadly neutralizing antibodies? Broadly neutralizing antibodies with the ultimate goal of having a passive transfusion of broadly neutralizing antibodies, which are being rapidly developed now, so that instead of taking a pill every day, perhaps if you can modify, and I know we can, the molecule to last longer than every 2 months, that you can actually come in every 6 months for a regimen of passive transfer. And that could hopefully replace antiretroviral therapy the same way as mentioned here, that these type of long-acting drugs can actually replace the need for a daily pill. Okay, now what about new and improved tools for prevention? Again, two key priorities. The first, pre-exposure prophylaxis. And again, that can be long-acting ART-based prophylaxis or long-acting broadly neutralizing antibody prophylaxis. Let's look at the ART-based. Two major trials, cabotegravir versus Truvada for PrEP in a large number of men who have sex with men and transgender women in multiple countries, as well as one that's still ongoing of 3,200 women in sub-Saharan Africa. Let's take a look at HPTN 083. Again, the results of this study were reported at the AIDS 2020 meeting, and there was a 60% lower incidence in the cabotegravir group, and it actually outperformed the daily pill of Truvada. This is very good news for the adherence of individuals who are PrEP. In addition, the vaginal ring for HIV prevention received a positive opinion from the EMA, and it announced that it adapted this positive scientific opinion on the dipyridine vaginal ring for use by cisgender women age 18 and older in developing countries. Moving on now quickly to broadly neutralizing antibodies, one that we can actually modify to last for a long period of time. A very important study called antibody-mediated prevention is being conducted, and in fact, the results, if they have not already been announced by the time this talk gets to you, they will shortly be announced, have been now in multiple continents here shown in the red dots in HPTN 703 and HPTN 081. We are cautiously awaiting with some optimism the results of these trials. And then there's vaccine. As I've said so many times, if we're talking about the durable end of the HIV/AIDS pandemic, we will need a vaccine together with the prevention modalities that I just mentioned. There are two major approaches to an HIV vaccine. The first, to empirically test candidates to identify correlates of immunity. That's classical vaccinology. We did that with the RV144 response. It had a good 31% not ready for prime time prevention. But in order to really do better, we need to increase the strength, the breadth, and the durability with multiple boosts, modified vectors, adjuvants, and mosaic antigens. That is being done in 3 separate trials that are taking place internationally. The UAMBO, which was not successful, much to our dismay, but we have faith and hope, as it were, and some cautious optimism into other studies that are being done, the HVTN 705 and HVTN 706, the latter one using mosaic antigens in the trial. Now, let me just close by going on to HIV vaccine which is assuming a correlative immunity as opposed to empirically testing a vaccine to identify the correlative immunity. You assume a correlative immunity and you design a vaccine to induce that correlate. And the assumption of the most relevant correlate we know historically is a broadly neutralizing antibody that you hope you'll be able to induce by a vaccine that might afford protection against acquisition of HIV. And in fact, the passive transfer of the broadly neutralizing antibodies, as I showed in this slide, where it was a phase 2B study of the monoclonal antibody, the broadly neutralizing antibody, VRC01, the results of this will inform us as to the feasibility of getting a vaccine. So let's get back to this. What you would do is you assume that these antibodies can be induced by a vaccine. And the real challenge right now is to take those multiple epitopes that are on the envelope protein, as shown on the left-hand part of this. And those were identified by monoclonal antibodies from people who've recovered or are actively infected, not recovered, excuse me, but people who have actively been making antibody against this particular epitope, and to clone the antibody and to actually show that it binds to a neutralizing epitope. The real challenge is going to be how to get those epitopes in the form of an immunogen that could be used in a vaccine to induce the same broadly neutralizing antibodies that were actually originally derived by showing how they bound to these neutralizing epitopes. So in conclusion, we do believe we can end the epidemic in the United States. And if we can do that, then I believe we can end it globally, because many of the principles that I have mentioned, they'll be different from country to country, but the principles that I've mentioned over the past several minutes is by maximally implementing the current HIV tools that we have for both treatment and prevention, and adding and complementing that with the continuity and continually getting new and better treatment and prevention tools, including the kinds of things that I mentioned to make treatment more user-friendly, and above all, the holy grail of prevention, a safe and effective vaccine. So thank you very much for giving me the opportunity to give an outline of where we've been, where we are, and where we hope we'll be able to go as we continue into this decade aimed at ending the HIV epidemic in the United States and hopefully globally.
Thank you so much, Dr. Fauci, and to Secretary Azar and Administrator Engels for a great start to the National Ryan White Conference. I'm really excited that we really seem to have the tools we need to prevent HIV in the absence of that vaccine. Please do not forget to fill out your evaluation form for this session. We review all of your input closely and to fine-tune this meeting and plan our next national conference. To find the evaluation for this session, navigate to the agenda page on the virtual platform and select this plenary session. There you'll find the session evaluation link within the session description. Thank you so much for being with us this afternoon. The first workshop is going to begin in about 45 minutes. That's 3:15 Eastern Standard Time. Tomorrow, the workshops start at 10 a.m. Eastern Standard Time, with the next plenary on optimizing public health beginning at 11 a.m., kicking off with an important plenary on community engagement. Stay safe and enjoy the remainder of the conference. Thank you so much for joining us this afternoon.